Right, so just where we left things is with this paper by Rocco et al. And they explicitly recognize that while social capital may affect health, health may affect social capital. And so here we're moving away from a single equation approach and having two equations, or sometimes described as a simultaneous equation model. And so in the first equation, the health measure is self-reported health, and it's being regressed on a measure of individual social capital and a measure of community social capital. Recalling, if we go back, yes, it's this one here. There's various ways you could measure, or they measured, community social capital. Their measure was the average of the individual level of trust, but the average across different groups of individuals. Individuals defined by age group. Right, so those are the different ones. So these are simply different measures of community social capital. And then they're finding themselves in the equation here at this point. The Z and the X are, again, a series of control variables. And so that's the first equation. Health depends on social capital, that's individual social capital, and on community social capital, and then on a whole lot of control variables. In the second equation, it's explicitly modeling individual social capital as a function of self-reported health, community social capital, and these control variables. Now, I won't go into the statistical econometric complexities of it. They don't really matter for our purposes. But the key point is this: if you do believe that social capital is to some extent a function of health, if you just estimated equation 1, you're going to get the wrong answer, as it were, as to what effect social capital has on health. If you don't allow for the relationship possibly going in the other direction, if you don't allow for the idea that social capital and self-reported health are, as it were, created together, they're determined simultaneously. So what this author's trying to do is to say, well, a lot of studies have just regressed health on social capital. I'm going to, while doing that, I'm going to regress social capital on health in the same simultaneous model, and thus allowing for that relationship that was emphasized in the earlier paper. I flashback. Yep, there we are. Scheffler, and he was arguing, yes, there's an important relationship from social capital to health through these mechanisms, but there's likely then to be a move back from health into the social capital. And so this paper I'm now finishing with by Rocco is explicitly trying to test that. So let's see what they found. Right, this time I've made it look a bit more like a regression. I've actually put numbers in. Before I was just, putting in positive, significant, negative, significant. All these are to some extent significant. The level of statistical significance is of course arbitrary, but in this example, 3 stars is a significance level of 0.01, 2 stars for the 5%, and this is, well, significant at 10%, but you might argue that's not really significant. 10% is a little bit high. So what have they found? Well, so we've got 2 equations. One equation determining individual social capital, another equation determining the self-reported health. If we look first of all, individual social capital, what they found was that there was quite a strong negative relationship between the individual's social capital, how much they trusted people, and whether they'd been a victim of burglary or assault in the last 5 years. Now that's not perhaps too surprising. If you've been a victim of burglary or assault, you are possibly less likely to trust people. So that could be taken as, it's not positive, but it's positive in the research sense, that it's perhaps suggesting, it could be interpreted as some suggestion of validity, that your measure of social capital, it's behaving as it should, it's related to that variable. And importantly, what they found was that the individual's self-reported health has a strong positive relationship with the individual's social capital. So in other words, individuals who report high degrees of trust also reported high health status. And then finally, they found a positive relationship between the community social capital and individual social capital. Remember, the individual social capital is the extent to which you trust others. The community social capital was a sort of reference group, peer group, average level of individual trust, and found a strong positive relationship. So that's one equation. The second equation determines health, and health is partly determined here by number of doctors. Good news for doctors, although we spend a lot of time saying there's a lot more than healthcare to impact health, but number of doctors in the region in which the person resided has a strong positive relationship with self-reported health. Community social capital has a positive relationship, maybe not statistically very strong, with self-reported health. And individual social capital has a strong positive relationship. So what this is showing is this circular relationship between social capital, or these results are showing, between social capital and health. So this study is very interesting in that it's documenting this phenomenon that I've been alluding to throughout the lecture, that maybe we can't just focus on the effect of social capital on health. We have to take into account the sort of feedback loop. This study shows that community social capital, as defined here, the average of individual levels of trust among your reference group, community social capital has a positive influence on both individual social capital and on health. And the final point I'd make here is that the beneficial impact of social capital on health is at least an order of magnitude greater than that of community social capital on health. So if we're looking at social capital's influence on health, and looking at the size of these coefficients, the individual social capital is at least 10 times, but rather more probably, stronger effect than the community social capital. Now, of course, that might be relevant for policy purposes in that it becomes more important possibly to work on somebody's individual social capital and not quite so important maybe for community social capital. So that's quite an interesting study, and that was the one I wanted to finish with. And so, just to summarise, how I would characterise social capital in health economics is as follows. As I've said, I think health economists joined in this research area a bit later than many other researchers. But having joined in, I think we can characterise the contribution of health economics or health economists in this area as partly being increased or greater emphasis on theory, partly also a greater interest in causation rather than association, and certainly health economists have been very keen, if they observe an association, not to claim any more, just to say they're associated. They're not without additional evidence would they ever say the relationship is causal. I think there's been progress, but I'd also have to say it's not particularly rapid. You know, we're learning. Each year there's a few more papers. I think a feature of the health economics work, and it's probably true of a lot of work on social capital by other disciplines, is there's a reliance on existing data. So it may be data that was really collected for another purpose. And then you're using that to try and demonstrate the relationships. And so that's to some extent a little bit of a weakness if you're sort of looking around for something you've got data on and then saying that might be an indicator of social capital, I will use it. Rather than starting with what is social capital, ideally how could I measure it?